Okay. Y'all, everybody ready? Thank you, ladies and gentlemen. We appreciate y'all attending our meeting today. We're going to go ahead and call the meeting to order. We'll be hearing from several of the attached agencies today, so we can be moving along with that. And first on our list is LaShawn Hughes with the Georgia Composite Medical Board.
Thank you, Mr. Chairman. I am LaShawn Hughes. I'm the Executive Director of the board. I have my board member who's going to make the presentation today.
My name is Dr. Marion Lee. I'm a member of the board, have been since 2008. I appreciate your time, Mr. Chairman, and members of the committee for allowing us to have this time to discuss our budget with you. Today I want to go over some of the agency's activities, some of the issues facing the agency, and the governor's fiscal year 2012 recommendations. And we have a PowerPoint slide to your right if you'd like to look at that. The medical board's purpose is very focused and straightforward. We license applicants to practice medicine and closely related to other medical activities, including physician assistants, respiratory care professionals, resident physicians, acupuncturists, perfusionists, orthotists, and prosthetists. We regulate their practice by establishing and enforcing professional standards through rulemaking and enforcing those rules. We guard patient safety by investigating complaints and providing information to allow informed decisions by healthcare consumers. Our licensing activity ensures that physicians and other professionals are qualified and meet the standards of professional conduct that the board has established. Today we oversee 41,000 licensees, including 31,000 physicians and 1,700 resident physicians. Physicians make up nearly 75% of our active licensee population. You can see by looking at the graph, over the past 7 years, the number of licensees has steadily risen. Today, with the same number of actual staff members, the board oversees 21% more active licensees. This graph goes from 2004 to 2010. Our budget has been neutral or declining over that period of time, and you'll see that our cost of performing the service has dropped per applicant from $83 to $44, a reduction of over 46%, thanks to the board's efforts at efficiency and proper management. Concurrently, our enforcement requirements have increased dramatically. The number of complaints that we receive and review over that same period of time has risen by 79%. The types of cases that we investigate are varied and include unlicensed practice, unprofessional conduct, malpractice, impairment, prescribing issues, sexual misconduct, and malpractice settlements. Over the last fiscal year, we issued 3,000 new licensees. We reviewed 2,145 complaints. We reviewed 826 nurse practitioner prescribing protocols, renewed 18,713 licenses. We collected approximately $103 per licensee, which is over twice as much as was expended per licensee for each activity. The medical board also serves a purpose in the community. The management team and the board members spend time presenting lectures and leading discussions at Georgia's medical schools, professional associations, and in other venues to promote safe practice. They volunteer their time and expertise at charitable and free clinics, and we work with groups on issues like pain management, healthcare quality, healthcare access. Our board maintains physician profiles, which anyone can access by going on the website. This was done under the Patient Right to Know Act in 2001. Over the past 2 years, nearly 500 profiles are viewed every day. 9 out of 10 of these profiles viewings are of 4 or less licensees, indicating that 90% are actual consumers that are using this database to make informed decisions about who should provide their health care. During this time, our enforcement costs have gone up, but this is a necessary activity for public safety. Our fiscal year 2010 revenue collections are displayed on this slide and show that we return at $2.09 for every dollar that is spent on the board's activities. The fiscal year 2012 revenue collections are estimated to be at $6.2 million, and we expect that this will be a 70% or more increase secondary to the fee increases we implemented last year after discussions with you and the Senate. The Governor's 2012 budget recommendations have included co-locating the Georgia Board of Physician workforce with us. This will create efficiencies that could save the state over $250,000 every year. Elimination of rent and duplicated equipment leases will save approximately $82,000, and efficiencies gained from sharing staff and cutting vacancies approximately $170,000. I hope that this has been an informative presentation for you. The medical board is of great value to Georgia. We generate positive revenue, we ensure health care quality and safety, and we provide essential health care information for our fellow Georgians. If you have any questions now or in the future, please feel free to contact us, and we'll be happy to work with you. Thank you.
Doctor, thank you very much. Are any questions from members of the committee or Representative Stevens?
How many agents do you have?
We currently have 5.
Has that been level for?
We've had 1 agent died and 1 retired that we haven't filled those positions.
Okay.
A couple of historical questions, if I could, Mr. Chairman. How long have you been no longer in the Secretary of State's office, instead in the Department of Community Health?
Since 1999.
Since 1999, so it's about more than 10 years. I hear complaints from the other health boards about how the functioning is at the Secretary of State's office, and just wondered if there is any discussion about bringing other health boards into the Department of Community Health. I mean, it seems like the kinds of investigators that you have would benefit from a kind of having a lot of people. Has there been any discussion about that?
We've heard from members of the psychology board that were interested in combining to have a healthcare board, and most of our agents were once with the Secretary of State's office, so they're used to investigating those cases as well as medical board cases.
But I mean, I guess you could tell whether it's been more efficient, more been able to do your work better in that department rather than in the other department where there are a number of really unrelated kind of professions.
I don't want to trash the Secretary of State's office, but we think we're more efficient.
Thank you. I don't mean to trash the Secretary
Right.
of State's office either. They are underfunded as well.
Right.
So I just wondered if there are efficiencies by having boards who do related things, not related to this budget, obviously, but it was a question that was in my mind. Thank you.
Any other questions? Thank you very much. Appreciate the good work y'all do.
Thank you.
Okay. Next, we're going to hear from Bill Todd with the Georgia Cancer Coalition.
Thank you, Mr. Chairman. I am Bill Todd, Director of the Georgia Cancer Coalition. I've done this work for 8 years, and I'm honored to do it. It's a noble work, and I appreciate this opportunity to be with the committee this morning. My primary message to you this afternoon is that your investments are paying off handsome dividends. Our mission, of course, is to reduce the number of deaths due to cancer and to make Georgia a leading state in cancer care in the nation. And it indeed is working. The private sector actually got a jump start on the state, getting into this major effort in the late 90s when the tobacco settlement came in the early part of 2001. The state became a partner in this public-private partnership, and it's paying off handsome dividends. The one that's most impressive is that the number of cancer deaths per 100,000 continue to go down. That number was rising. That graph was rising until 1994. Nationally and in the state, and primarily due to reduction in tobacco products and smoking rates and others. It is going down now. In the early part of this century, we did cross the line and improve upon the national average. So we're better than the national average now by 1.5%. That's 150 people every year who are living in Georgia who would not have been in earlier times. Similarly, as you'll see on the next chart, the rates of clinical trials participation are higher than the national average in Georgia. This is very important because clinical trials, of course, are the way in which new discoveries from laboratories get to the patient through the bedside, to the bedside from the laboratory. And we're very pleased with that. It's a hard thing to do. One statistic that is directly related to the reduction in deaths is the improvement in breast cancer screening rates. We have a number of people, the Department of Community Health does a wonderful job through the Breast Test and More program. We have a number of private sector folks involved in this, hospitals throughout the state. It's very nicely coordinated. The breast cancer license tags generating about $1 million a year for indigent women, and we're doing much better than the nation in breast cancer screening rates. We're moving to the national leadership level in several areas. Emory was designated as an NCI center in April of '09. That was a critically important issue where we had spent most of our time in the first 9 years of helping that to happen, joined by a number of very significant donors from the private sector. That's the backbone of the NCI strategy in Washington, so we're now on the right page with the nation. There are 30 NCI community cancer centers in the country. We have 2, one in Savannah with branches in Columbus and Rome, and then one in Sandy Springs. And in 9 communities around our state, the private sector, through their hospitals, have developed cancer centers, and that is the current way in which the best cancer care is delivered, where the patient goes to one place, one facility, and receives all of the services that she needs. We do have the state's first statewide clinical trials network, as I mentioned, and we have one of the steepest slopes on the curve of NCI funding in the nation, which is very important in moving, again, new knowledge to the bedside. Our comprehensive cancer control plan is ranked #1 in the nation by the CDC, and we're fortunate to have both the American Cancer Society and the CDC in our backyard, so we benefit from that. And all that to say is now is not really the time to slow down. We've said from the beginning that we can do well as a state by doing good. By focusing on this mission of reducing the number of deaths, we can actually have some improved economic development benefits. And there are 5 ways that we can do that. One is in the care of cancer patients. There are 40,000 new cases a year. 11% of them, unfortunately, leave the state for their care. These are not indigent or uncompensated cases, but these are the people who have the ability, like we are blessed to have, where we could say we'll go wherever the best care is. And 4,400 people do leave, and that means that the largest employer in many communities is deprived of that business. So the more we can retain those people, we give them better care and get the benefit of that business. We can also form new startup companies based on the discoveries that come out of our laboratories. Just last week, an Emory, Georgia Tech nanotechnology company was formed at the ATDC based on some new work on research funded by the NCI there. We can attract companies to come to Georgia because they want to be around this brain trust. There are now 158 of these distinguished cancer clinician scientists, and that's a strong pool. We've seen that happen in South Fulton County, a company called Dendreon, located there in order to be around this brain trust. And, of course, we can continue to grow the federal and private research funding, and that has a direct impact on the economy as you hire more technicians, research nurses, data managers, and others. And, of course, the system-wide is it is better for our economy when people are healthy. I'll be talking about 40.22 in the governor's budget recommendations for 2012. And you'll notice in the research category, 3 reductions, $662,000 for the cancer scholars, $19,000 for tissue banking, and $20,000 for clinical trials, reductions of $701,000. In the prevention area, there is a reduction of $108,000 and then $256,000 in our operations. The impact of that, Mr. Chairman, ladies and gentlemen of the committee, is as follows. When we reduce by $662,000 from the cancer clinician and scientist, that means we'll meet all the current obligations, but we'll add no new people. We'll not recruit any more of these distinguished cancer clinician scientists from the best cancer centers in America to come to our communities. The last 7 of which didn't come to the medical schools directly, but they came to community hospitals in order to work in a liaison capacity with the academic medical center. So we'll not be expanding that. And in addition, we'll have to reduce the number of awards that we've already made. It's a 5-year payout. For a full professor, it would be $150,000 per year for 5 years, and we'll have to reduce that by $20,000 for a full professor, $10,000 for an associate professor. And you can do the math pretty quickly and find out that will reduce the awards coming in from federal sources by about $4 million. It's a real cause and effect relationship. And there's a danger when we evaluate the impact of these folks being in play, because they might feel like their commitments have not been met and they would be more susceptible to be recruited elsewhere. In the biorepository, the tissue bank, we will not need to reduce anything, but we'll not be able to grow either. We had several communities, Athens, Gainesville, and Carrollton, where we wanted to expand this program, and we will not be able to do that based on this reduction. In our clinical trials effort, it's a joint venture with GASCO, the Georgia Association for Clinical Oncology, and we will have to take a back step on our efforts to get into the GYN oncology in a big way and eliminate that program. This committee has been very interested in the Regional Cancer Coalitions of Georgia, and for good reason. They've done great work over the last few years, being our partners in dealing with the grassroots and getting to the patients wherever they are. So these screening programs in particular and education programs are brought to them, and this reduction will undoubtedly mean some furloughs in those organizations. Those are 6 private 501c3 corporations that we have contracts with. They do good work. We need them. They'll be challenged. And coalition operations will reduce 73,000 across the board in a number of things, including some consultants, travel, and meetings. The one that has the greatest impact, Mr. Chairman, is in elimination of a chief operating officer position. That's understandable that we don't need that much management, because we've gone from a staff of 9 to 4, and this would then be just 3. One way to think about it may be to take advantage of some private and federal funding that has really come in since the governor's budget recommendation has been put together, and zero this position out in order to make the numbers work, as you have suggested, reduce it by 183,074, but to recast it as a director of survivorship programs and patient navigation, where the incumbent is uniquely qualified to do that work as a cancer survivor herself. We've had $1.7 million in a federal grant and $250,000 in a foundation grant come in. And one thing you might want to do is just zero that out with the $183,000 of savings, and then let the private and federal funds pay for that position. And then there's a housekeeping matter of the transfer from the Regents to the Georgia Department of Economic Development, the entire balance $9.2 million. And the strategic synergies that could be realized with working closer with economic development are real. We can certainly do that. We can make that work. One way I think about that is, who do we work with on a daily basis? I mean, we're here in this committee because we work with the people that you look after, the healthcare community. When we do those things well, then we have an economic outcome, and we certainly can do the 5 things that I mentioned earlier about having a positive economic impact on the state. But day in, day out, we work with medical schools, research universities, hospitals, public health, CDC, NCI, the regional coalitions, the volunteer organizations like the American Cancer Society, Lance Armstrong, Komen, and others. So it'll work either way, whichever way you think is best. But you might want to think about who do we work with on a day in, day out basis. Glad to answer any questions, Mr. Chairman.
Bill, thank you. Y'all do important work over there. I don't think there's anybody that hadn't been touched either directly or indirectly by cancer, and y'all certainly realize how important it is in what you do. Are there questions among the committee members for Mr. Todd? Well, I have, you touched on this, but I want to ask you to go into this a little more, talking about the move from the Regents to the Department of Economic Development. And what I understand, part of the reasoning behind that is to use their marketing skills and opportunities over there to promote Georgia's cancer centers in this state as an industry, I suppose, for lack of a better word. Like, so many times we hear now about somebody leaves here and goes to MD Anderson or something like that, and you mentioned that 11% of those folks that have cancer leave the state for care because they have the means to make that trip. But the real truth is that we have a lot of great facilities and people in this state, and I think sometime maybe the word just hasn't gotten out. So those 11% that are leaving, many of those could be treated just as well, if not better, right here locally. And I think that's part of the reasoning behind that. And do you want to comment any more on that or talk to us about any of that?
Well, you're exactly right. We are convinced that our reputation lags our capabilities because we were a little late getting out of the gate. We were one of the last states of our size to have an NCI designated center, and that was the very reason many people chose to go elsewhere, and they need to know that we have that plus the hub and spoke mechanisms in our other communities to relate back to that NCI designated center. So I have met with Commissioner Comiskey, and we welcome the opportunity to use their marketing prowess to tell that story. It does need to be told, and it is an industry. Many of our communities, healthcare is the largest employer, and cancer is a big piece of that. The key, I think, for the committee to discern is whether, at what point do you intervene to tell the story. You got to keep your eye on the ball to get the work done to be a rising star, and we wouldn't ever want it to be the other way around. You wouldn't ever want it to be you were blowing smoke about something you couldn't deliver on. In this case, we're lagging. Our reputation is lagging our capability, but the work is not finished on building a world-class cancer care system. And the people that we work with on a daily basis are people in healthcare, people this committee oversees.
Are you telling me you think it's better served where it is or under the Department of Economic Development?
We can make it work either way, Mr. Chairman. That's
a good answer. How about any other questions from the committee or anybody? Got one over here. Representative Sims, go ahead.
Thank you, Mr. Chairman. I'm just interested in the screening portion. I know that screening is so important, but can you give me a definitive number of how many screenings you do, how many are detected by that screening?
One of the trickiest things about the word coalition with a small c, the reason we try to bring this whole community together is because it is so disaggregated. It is so fragmented. There's so many people, good, well-intentioned people involved, and we don't have that number. We really don't with all of the people, hospitals, communities, the DCH, the program we have with the breast cancer license tag. We're working toward getting that. Komen does an awful lot individually. We're trying to bring all the interested parties together in that in a number of areas and to be able to talk about not only the impact but the basic need. But there are good data that I can get you about the yield from breast cancer screening overall, and why it makes good sense, and it's the right thing to do not only for the woman but also for the cost of care. It's much easier to find a breast cancer lesion at stage 0 or 1 where it can be cured than at 3 or 4.
Thank you.
Bill, talk to us just a minute about the tumor tissue bank. This is where y'all are collecting these samples over a period of time, and then the scientists use those in their research. Is that correct?
That is correct. When a tumor is excised from a patient, it's frozen right there in the operating room and processed at the hospital and shipped to Augusta, to the medical college, where it is characterized. In other words, it's put through the analysis for the DNA, and then it's available to the scientist who's looking for patterns. That's the way they're making progress so much in cancer research, is patterns like in triple-negative breast cancer. That's the way that happened. It's the leading edge to what will happen within a few years, maybe as short as 5, where when a patient is receiving chemotherapy, they will have had their tumor, their biopsy characterized, and their cocktail, their their infusion of medicine will be concocted just for them based on their own DNA. So today it's an important research tool. Soon, and tomorrow, it will be a treatment modality. It's very important that we be able to get this bank and get hundreds of thousands of samples so it can be statistically significant, so that the therapeutic side of it can be realized when it comes about in a few years. There are already some experimental sessions where people are getting their chemotherapy based on their own DNA, different than everybody else's.
How long have we been collecting those samples?
Since about 2004.
Are we to the point, or getting to the point, that that could sort of become self-sustaining? By that I mean, once you have collected the proper number of samples, and I guess that's an ongoing process, that if the scientists request those samples or something, that they would be charged some sort of a fee to help pay for that process? Or are we moving in that direction, or where are we?
We are. It does have an opportunity to not only have a fee-for-service basis where the grant that they're using to fund their work is paying for that service, but also the federal, the NCI is putting so much more emphasis on it. There's opportunities for us to write grants and have that funded by the federal government. And it's another example of how the state, in many ways, is putting the first dollar in to make something happen.
Good. Any other questions? Thank you very much.
Thanks, sir.
Okay, next, Sherry Tucker is going to do State Medical Education Board, I think.
Margie. I think she has to do something. Okay. I can go ahead.
Sherry, let's go ahead. We've got a handout sheet here,
Okay.
but next time you print these, now you're
I
going to have
will
to print them larger so
I
we
will,
can,
just so in case
us old
this
folks can
happens
see
again.
them over here.
In case this happens
they're,
again.
they're trying to get some help on this.
Okay. All right. Thank you, Mr. Chairman. My name is Sherry Tucker, and I'm the Executive Director of both the State Medical Education Board and the Georgia Board for Physician Workforce. And thank you for allowing me to appear before you today to present the Governor's budget recommendations for both boards. I'm starting with the State Medical Education Board, and the purpose of that board is to recruit physicians to rural communities throughout the state. Specifically, the board helps bring about an adequate supply of primary care and other needed physician specialists in rural Georgia by providing medical education scholarships and loan repayment opportunities for medical students and practicing physicians willing to practice in a targeted rural community. The State Medical Education Board was created by the Official Code of Georgia 23510 in 1952. Georgia was among the first states to establish a scholarship program for rural physicians. Now in its 59th year, this is the longest standing program of its kind in the country, and this program has served as a model for other states and the federal government as well. The board consists of 7 members appointed by the governor. The programs of the State Medical Education Board, we have 3 basic programs. The scholarship program, which is also known as the Country Doctor Scholarship Program. We have a loan repayment program, and we also sponsor the Georgia Medical Fair each year. And I'm just kind of going to answer some basic questions with all of these programs, such as why are we supporting these programs? And these programs help ensure an adequate supply of primary care and other needed physician specialists by awarding service-cancelable scholarships and loans. And according to a study of private practice physicians in Georgia conducted by the Carl Vinson Institute of Government in 2008, each private practice physician in Georgia supports up to 13 additional jobs, $640,000 in personal income for those jobs, and between $700,000 and $1.5 million in total economic activity. All right, hold on just a second. And who are our customers? Our immediate customers of the SMED programs are medical students and medical schools, resident physicians, and private practice physicians. Long-term customers of the SMED programs are rural hospitals, medical facilities, rural communities, community health centers, and Georgia citizens that receive medical care from these physicians. During 2010, the State Med Board website had over 5,000 visitors and over 16,000 page views. This website outlines the programs of the board, provides application materials, and other information on medical programs in Georgia. The SMEB Scholarship Program, just some background and history on it. It's also, as I said, called the Country Doctor Scholarship Program. Over 1,600 physicians have participated in this program since it began in 1952. We currently provide up to $20,000 each year in tuition support for Georgia medical students attending a U.S. medical school. Recipients are required to practice in a Georgia county of 35,000 or fewer people once they complete their graduate medical education program. And currently, based on the 2000 census, we have 109 counties that qualify under this program. 1 year of service is required for each year of support. So if they get the scholarship for 4 years, they have to work in the community for 4 years. In fiscal year 2010, 26 scholarships were funded, down from 30 in 2009. And in 2010, 7 recipients began practice in rural Georgia. And in fiscal year 2011, 13 recipients have indicated they will begin practice in rural Georgia. With the scholarship program, what are we buying? Well, what the state is buying is an affordable, quality medical education for students who might not be able to afford to attend medical school. Another interesting statistic is in fiscal year 2011, we had 28 student recipients in the completing their 4 years of medical school, and that was down from 43 students in medical school in 2004. How is the program working? Most recent scholarship recipient data collected over a 7-year span shows that 79% of the scholarship recipients remained in Georgia to practice after completing their scholarship obligation. 42% remained in a county of 35,000 or less population, and 89% of those who remained in Georgia are practicing primary care or a core specialty, which is defined as family medicine, internal medicine, pediatrics, obstetrics, gynecology, and general surgery. How much does the scholarship program cost? Currently, we're paying $20,000 per year for up to 4 years. The state investment during the most recent 7-year period analyzed, the state paid $2.3 million for scholarships. 64 physicians remained in Georgia have produced approximately 832 jobs, and this year will yield between $44.8 and $96 million in economic activity. For every $20,000 Georgia has invested in scholarships, the state will yield between $369,000 and $834,000 annually in economic impact. The next program is the loan repayment program. We also call this the Physicians for Rural Areas Assistance Program, and it's funded by state dollars only and provides the payment of outstanding medical education loan debt for participating physicians. It provides point-of-practice funding that makes rural practice locations viable for physicians. And the ability of rural hospitals and municipalities to bolster medical practices is waning, and this program offers a financial incentive that enables rural practice. What are we buying with the loan repayment program? We're buying the services of well-trained, dedicated physicians who wish to live and work in rural Georgia. Many of these physicians would consider the cost of rural practice too high without the assistance of this loan repayment program. We're also buying improved access to health care for the citizens of Georgia living in rural, underserved communities, particularly the uninsured, underinsured, the Medicaid population, and the participants of the Peach Care for Kids program. How is the loan repayment program working? In the 16 years since the loan repayment program began, 81.9% of the participants have remained in Georgia to practice after completing their obligation. 58% of those retained stayed in the same county as their obligation, and 75% still remain in a qualifying county, which is a population of 35,000 or less. The cost of the loan repayment program, we pay up to $25,000 per year for up to 4 years, but in the last several years the board has chose to only award $20,000 and able to stretch the money and provide the payments to more physicians. During the 16-year period since the program began, the state investment is $3.9 million. Of the 95 physicians that are remaining in Georgia, they've produced approximately 1,200 jobs, and this year will produce between $66.5 and $142 million in economic activity. And for every $20,000 spent on a loan repayment, the state has yielded $317,000 to $702,000 annually in economic impact. The final program of the State Medical Education Board is the Georgia Medical Fair, and this was established in 1979 to provide a low-cost, effective way for rural communities to recruit physicians. This program has become a model that has been replicated by many other states. Over 400 physicians have been recruited to rural Georgia through the medical fair. Rural Georgia communities and hospitals realize significant economy through person-to-person access to an average of 75 physicians throughout their GME training. Communities are able to place themselves in a current health care market in Georgia through interaction with other rural communities and physicians in training. We support this program because it's key to physician retention. It allows a well-informed choice of practice location by giving the physicians direct and continuing first-hand contact with a variety of potential practice opportunities. At its inception, the medical fair was used only as a way for the State Med Board scholarship recipients to locate a qualifying practice site to service their obligations. But since that time, now we've opened it up to any physician or medical student who's interested in rural practice. What do we provide through the medical fair? It provides the well-informed choice of practice locations. It provides rural Georgia communities a cost-effective way to access physicians on a one-on-one basis. And we also provide valuable seminars and continuing education courses ranging from topics in practice management and contract negotiations to addressing cultural diversity and medical ethics. And we do this all over about a period of a day and a half. The customers of the medical fair are 30 to 40 rural communities and usually 75 physicians and medical students. Long-term customers are the hospitals, medical facilities, communities, and Georgia citizens. The medical fair budget for 2010 was $43,725 in state funds. We also collected almost $26,000 in registration fees, and the total cost of the medical fair was right at $69,000. The most recent medical fair statistics show that 89% of the physician attendees indicated an increased interest in rural Georgia after attending the medical fair. 71% of the physicians who attended the medical fair remained in Georgia to practice. Of the 71 that remained in Georgia, 31 currently practice in a rural Georgia county, and 82% of the physicians who attended the medical fair went on to practice in a primary care specialty. The governor's budget recommendations for the state med board for fiscal year 2012, on the tracking sheet it's listed as 1729.1, and it's to transfer the funds for the medical scholarship and loan repayment program to the new Physicians for Rural Areas program to reflect the consolidation of the State Medical Education Board with the Georgia Board for Physician Workforce. So that's a reduction in the State Med Board budget of $790,000. 1729.2, pursue private sponsorship for the medical fair and reduce the state funds. $42,723 reduction, which eliminates all state funds for the medical fair. 1729.3 is transfer of state funds from the State Medical Education Board to the Georgia Board for Physician Workforce Administration program to reflect the consolidation of the boards, a reduction of $229,983,000. And 1729.4 reduce funds for the medical scholarship program of $80,000, which leaves the budget for the scholarship program at $500,000. I'll be glad to answer any questions the committee may have on the State Med Board.
I think we have some questions for you, Jerry. Good presentation. Representative Stevens.
Wow. Thank you, Mr. Chairman. Have you got a breakout of where the scholarships go? In other words, we've got some private medical colleges. Do they get any of the scholarships?
I don't have that with me, but all of the medical schools in Georgia right now, I don't believe we currently have a scholarship recipient at Emory, but we have had in the past. They are at the other 4 medical schools. We also provide, they can go to any U.S. medical school, and we have several that are out of state at this time. Medical schools out of state, and we do fund these for the allopathic MD programs and the osteopathic DO programs.
So they can get the scholarship out of state? And
well, it's all for Georgia residents. Only Georgia residents can apply, but they can attend medical school out of state, not out of the country, but out of state. But they are required by contract to come back to Georgia and practice after their graduate medical education training. And if they default, they have to pay back what we call triple damages, which if they get $80,000, $20,000 a year for 4 years, and they default, they have to pay us back $240,000 within 90 days of graduating from their GME program, one lump sum.
Wow. No more questions, Mr. Chairman.
That's pretty good incentive to come back. Representative Gardner, you have a question?
Thank you, Mr. Chairman. I was just trying to get a big picture, a snapshot of the State Medical Education Board, even though I understand they're changing. Do you have something that you could send to me that shows your total budget and how it's divided up with loans, loan repayment? And I assume the medical fair is a very small piece of it. Mm-hmm. But it'd be interesting to see kind of where the people came from who got these loans, and where the repayment doctors went.
Okay,
Thank you.
We can do that.
Are there any, just following up on Chairman Stevens' question, how many students actually, receive their degree out of state and then stay out of state and pay us that incredible amount of money?
Within the last several years, we have returned probably good bit of money back to the state. Not a lot of them default. Some of them we do have. The one that comes to mind, just right off the top of my head, went to residency program. She went to medical school in Georgia, but went to a residency program in South Carolina. And the hospital where she did her residency there actually paid her default to keep her there instead of coming back to Georgia. The default rate is not that high, but it does happen.
Okay, thank you.
Jerry, talk to us a little bit about the proposed consolidation and sort of give us, the committee, a little understanding of what it is you do by wearing both hats for both of these different entities there, what the consolidation is going to mean, what savings would be achieved, if any, and how that would work. Could you address that a little for us, please?
Okay. Back in the early 2000s, the State Medical Education Board and Georgia Board for Physician Workforce staffs came together under one executive director. And 2 years ago, I took over in that position of executive director, and we currently have 5 staff members between the two boards. The State Med Board has 2 field staff positions. The Physician Workforce Board has 4, including mine. The 6 staff work for both boards. It's just sharing efficiencies and things like that. The consolidation is taking the scholarship and loan repayment funds and setting up the new program and moving the entire admin budget into the Physician Workforce Board admin budget. And the consolidation eliminates the 7 board member positions that we currently have, and the only savings aside from the budget reductions with the scholarship program, the medical fair, from the actual consolidation would be the elimination of the board member per diem and travel expenses related to the 4 board meetings we have a year.
Okay, thank you. Any other questions or comments from the committee? Okay.
In one of your slides, you talked about getting private sponsors for this medical fair. Do y'all have that lined up already, or?
No, we do not. In fact, we actually, the hotel we typically have the medical fair at the last several years, we had to call and let them know that we would not be able to sign the contract because of the budget recommendations to eliminate the funds. Because it would take us time to find sponsorships from outside sources. We do get a little bit of sponsorship from some of the rural health associations in the state, the various associations that help us pay part of a meal or part of the cost associated with the functions, but those are usually $3,000, $3,500 combined from the various associations. So going out and trying to collect $42,000 would be a larger endeavor, and we've just not been able to start that yet. So as of right now, there will not be a medical fair this year because we don't have the money to do it.
One further question, Mr. Chairman. So you're not going to have the medical fair this year. Can you tell us how the physicians are dispersed in the rural communities? Because you say they have to be in communities 35,000 or less.
35,000.
Okay. Are there areas in the state where we don't have any at all, or is it? How are they dispersed in those rural areas?
The State Med Board, aside from the medical fair, we don't tell the students where they have to go. It's basically up to the students to find a practice within one of the locations that qualifies. That's one of the reasons for having the medical fair. We get a lot of the qualifying communities there. I can send you a map or get you a map of those counties that do qualify, and then compare that with the physician workforce data about the number of physicians that are currently in those counties.
Thank you.
Didn't you tell us that there are like 109 counties that you could satisfy that obligation if you practice in one of those 109 counties?
Correct.
Okay. Had another question, Representative Garner?
I think maybe you told this, but I'm looking at 1729.1. Where is the Physicians for Rural Areas program? Is it in the...
It's in the Georgia Board for Physician Workforce budget.
Okay.
On the tracking sheet, it's up a few. And it's moving, I
Okay.
believe, 790,000
Oh, I see it.
over
Sorry. It's
under
in
the
big
other
print.
board.
Thank you.
Yeah.
Jerry, just on the medical fair that we talked about, the total cost of you doing that was roughly $70,000. And in the past, with this $42,000 you were getting, y'all were raising the other part, some $27,000 to $30,000 that y'all were raising on your own. When is the fair typically held? What time of the year?
We usually hold it in mid-September. And the other fees that you're talking about, the registration fees, we get those. The majority of that money comes from the communities themselves that attend. Last year we started a graduated step registration fee where they could pay anywhere from $500 to $1,000 to attend, and as they went up on the level, they got a few extra little perks and services with that. And then the resident physicians are charged $50, a non-refundable $50 fee, and students pay $25, and practicing physicians pay $75 if we get any of those in. Mid-September was when we hold it. I'll get back to that in a second.
All right. Any other questions or comments from the committee? Thank you very much, Jerry.
Okay.
Okay, next we're going to hear from Denise Carnegie, who's going to talk to us.
Oh, I got one more.
Whoop, excuse me. We were just going to do away with that other board there. I'm sorry. I missed a space here on my agenda. Thank you. Go ahead. I'm sorry.
Oh, that's okay. That's okay. The other presentation that I have is the Georgia Board for Physician Workforce. And the core business of the Physician Workforce Board is to monitor the supply and distribution of physician workforce in Georgia and to address the needs of Georgia communities through the support and development of medical education programs. For over 25 years, the Physician Workforce Board has been the sole entity responsible for identifying and quantifying the physician supply throughout Georgia. The Workforce Board's primary research is recognized throughout the nation as a benchmark for quality in physician workforce data. And just to kind of go back to something that LaShawn Hughes in the Composite Medical Board's presentation, they noted that there are approximately 30,000 physicians licensed in the state. And we work with them and take that information. We have some questions on their survey. And we pare the data down, pulling out retired physicians, physicians that are no longer practicing or practicing out of state. And based on our 2008 data, which we'll be releasing some reports in the near future on that, there are approximately 19,000 physicians actually practicing in the state of Georgia. The Physician Workforce Board's primary research and papers are routinely cited by and relied upon by policymakers and researchers in Georgia and throughout the nation, such as the Medical Association of Georgia, the Area Health Education Centers, the University System of Georgia's Center for Health Workforce Planning and Analysis, New Jersey Council of Teaching Hospitals, the Association of American Medical College, Georgia Health News, the Atlanta Journal-Constitution, and other news outlets, and it's also used by the Georgia General Assembly. The customers of the Georgia Board for Physician Workforce are the immediate customers are medical students in certain private medical schools, designated teaching hospitals and graduate medical education programs, physicians in training, hospitals, policymakers, researchers in Georgia and throughout the nation. Long-term customers are hospitals, medical facilities, communities, and Georgia citizens that receive medical care from these physicians. In 2010, the Physician Workforce Board's website had 3,600 visitors and 10,691 page views. We have all of our fact sheets, papers, and a physician resource application located on this website. The programs of the Physician Workforce Board are undergraduate medical education, which are Mercer's operating grant, Morehouse operating grant, and the Medical Student Capitation Program, and graduate medical education. The program area of undergraduate medical education, like I said, includes the operating grants and then the program we have called Medical Student Capitation, which pays for Georgia residents to attend a per student capitation rate for Mercer, Morehouse, and Emory. And we support these programs because the cost to run an average medical school is estimated to be $90 million a year, and the average cost to train a medical student is estimated to be $150,000 per year. In the 1980s, the Georgia General Assembly found it more cost-effective to enter into public-private partnerships with Mercer and Morehouse to ensure an adequate supply of primary care and other needed physicians instead of starting a new state medical school. And this is still a good investment today. The Medical Student Capitation Program provides opportunities for Georgia students to become physicians, and Georgia's 4 private medical schools educate 64% of the state's medical graduates. The next slide lists the medical school enrollment from 2000 and then a projection enrollment in 2020. And medical school enrollment has increased 48.5% over the last 10 years, from 1,500 medical students in 2000-2001 to 2,200 medical students in this current fiscal year, academic year. I just learned this morning that the Philadelphia College of Osteopathic Medicine is expanding their class size. So actually the projected enrollment for 2020 is going to be approximately 2,800 medical students, up from 2,754, which is shown on the slide. With undergraduate medical education, what we're buying is a quality medical education infrastructure that produces a well-educated and well-trained physician workforce. These physicians meet the healthcare needs of Georgia citizens, and current projections indicate an impending shortage of physicians at both the state and national level. The cost of the undergraduate medical education program expenditures for fiscal year 2010 were $33,021,647. This was divided up under the operating grants. The Macon campus in Mercer received $16,775,000. The Savannah campus at Mercer received $4.8 million. Morehouse School of Medicine received $8.9 million. The Medical Student Capitation Program, we paid $2.5 million out, or $7,800 per certified Georgia resident. Emory receives funding for 113 Georgia residents, Mercer for 210 Georgia residents, Morehouse for 93 Georgia residents. And I do want to note that under this Medical Student Capitation Program, the funding for Morehouse was moved into their operating grant in fiscal year 2010 to replace reduced funds in order to maximize the matching dollars on that. Contract deliverables for the undergraduate medical education program are that 50% of the medical school graduates must enter into a primary care core specialty graduate medical education program upon graduating from medical school. And the Physician Workforce Board defines this as the primary care specialties of family medicine, general internal medicine, general pediatrics, and obstetrics gynecology. And the board also considers general surgery as a core specialty. Based on the residency selection of medical school graduates in 2010, all of the medical schools in Georgia, even though we're only talking about 3 that we have contracts with, but all of 5 of the medical schools, 50% or more of their graduates are entering the primary care core specialties. Emory at 50%, Mercer 55%, Morehouse at 64% are the ones that we actually have contracts with. But Medical College of Georgia, 52% of their graduates went into primary care core specialty, and the osteopathic school in Gwinnett County, 64% of their graduates went into primary care core specialty. The next slide we put in, but even though the retention of graduates coming into Georgia to practice is not a contract deliverable for the undergraduate medical education program, we do report on the retention of graduates by medical school. And Mercer, roughly 59% of their graduates are practicing in Georgia, 52% of MCG's, 46% of Morehouse, and 37% of Emory's. So far, PCOM's graduates are still in residency training, so they're not out in practice yet. And once they do start hitting practice, we will report on theirs as well. But it's interesting to note that the national retention average for medical school graduates is 39%. And so most of our medical schools are above that national average there. Next, we have a map of where Mercer's alumni are practicing in Georgia, and as of June 30th, 2010, and that's just a showing of the various counties that they practice in the state. And we did also want to note, of the 480 graduates that are practicing in Georgia, they've created approximately 6,200 jobs and between $336 million and $720 million in economic activity in Georgia. The next slide is a map of Morehouse's graduates, all specialties, as of June 30th, 2010, the alumni that are practicing in the state. And of their 301 graduates practicing in Georgia, they've created approximately 4,000 jobs and between $210 million and $451 million in economic activity in the state. Next program of the board is graduate medical education, and this program includes capitation for designated teaching hospitals and certain specified residency programs. And we support this program because it helps ensure an adequate supply of primary care and other needed physician specialists through partnerships with Georgia's teaching hospitals and graduate medical education programs. What we're buying with this, what the state's buying with this program, is a quality medical education infrastructure. We're buying physicians to meet the health care needs of Georgia citizens and improved access to health care for Georgia citizens, particularly the uninsured, underinsured, Medicaid, and Peach Care for Kid population. The graduate medical education, the direct costs for GME training are estimated to be between $100,000 and $170,000 per resident per year, depending on specialty. Indirect costs may add another 30% to this cost. Fiscal year 2010 expenditures were $8.5 million for the designated teaching hospitals and GME programs. Family practice residency capitation is our oldest and largest program, where in 2010 we funded 197 residents at $20,260 per resident per year. Residency capitation covers all specialties, and we funded 1,154 residents at approximately $3,000 per resident per year. Pediatric capitation, we fund 50 residents in 3 of the 5 pediatric programs in the state. We do not fund all the pediatric programs. 50 residents at $16,692 per resident per year. Preventive medicine residency capitation, because of residents that graduate off cycle, 7.5 residents at $8,000 per resident per year. In 2010, we also started funding expansion capitation For the OB gynecology program at Memorial Health in Savannah, we fund 2 residents at $16.5 per year, and we also provided funding for the expansion of the general surgery program at the Medical Center of Central Georgia in Macon, and in 2010 we funded 3 residents at $16.5 per year. The contract deliverables for the graduate medical education program requires that funded hospitals maintain a retention rate of program graduates of at least 50% stay in state to practice based on a 5-year rolling average. The overall retention rate for graduates of the Georgia GME programs that we fund for the last 5 years was 63.1%, which is well above the national average of 47.4%. Family medicine programs had an average of 65% of their graduates stayed in state. Pediatric programs and preventive medicine programs an average of 56% of their graduates stayed in state. There's been some increase in accredited residency training positions in Georgia, but the increase is small compared to the medical school expansion. Over the last 10 years, residency positions are up 26%, and medical school enrollment is up by 48.5%. We also provided a chart, which I can get y'all a bigger copy of the total number of field residency positions and the total number of graduates by teaching hospital 2010-2011. We have 2,046 total field residency slots, and in 2010 we had 575 graduates from our GME training programs. The governor's budget recommendations for the Physician Workforce Board are located on the tracking sheet in the 1721 area. 1721.1 is Georgia Board Administration, which 1721.1 reflects an adjustment in the telecommunications expenses, $1,244. 1721.2 reflects a saving of co-locating the Physician Workforce Board and the Georgia Composite Medical Board and consolidating administrative support. And combined with the 2 boards, the total savings is $253,000. And in the governor's recommendations, the physician workforce is admin budget is to be reduced by $90,000. 17.213, transfer the funds from the State Medical Education Board to the Georgia Board for Physician Workforce to reflect the consolidation of the boards. That's bringing in the SMEB admin budget, $221,983. 1722.1 is the Georgia Board Graduate Medical Education Program. Reduce funds for Georgia residency programs. This is an 8% reduction, $675,866. And since 2009, this is a cumulative reduction of 17% in our GME funding for graduate medical education and the residency programs that we fund. 1723.1 Mercer School of Medicine operating grant. This is a 9% reduction in the funding for the Mercer operating grant, $1.9 million. 1724.1 on the Morehouse School of Medicine operating grant reflects the discontinuation of the ARA FMAP funds and replaced with state funds. When the stimulus money came about, the Morehouse operating grant was reduced to reflect the increase they received in the match for the stimulus money. So this is replacing those state funds, $3.6 million. 1724.2 is a reduction of 9% in the operating grant, as was with Mercer. It's a $1,055,421. 1725.1 is the transfer of funds from the medical scholarship and loan repayment programs for the State Medical Education Board budget to reflect the consolidation with the Physician Workforce Board. That's an addition of $790,000. And last is 1726.1, the undergraduate medical education program. Reduce funds for medical education at private institutions. This is a 10.2% reduction for that funding at $310,650,000.
Okay. Thank you for a lot of good information. Do you have any questions from the committee? Okay.
Let's see if I can find it back here. On page 7, there are 4 areas. That's not the right page. And you talked about the retention in Georgia of the family practice, the pediatric and preventive, but not the covers all specialties. Did I miss it?
The residency capitation, we're still compiling those, getting those in from the various medical schools. I mean, residency programs.
Would they be typical like the others that
Yes,
are over
it would be
50%?
over 50%. Yes, ma'am.
Okay. So I noticed on the next page you give them all a number, but you didn't give that one a number. And looking at the cuts, the 9% cuts to Mercer and Morehouse, what impact is this going to have on Mercer's ability to bring down? I know they get federal funds that Mercer doesn't get. I don't want them to lose any potential for federal funds, I guess.
If the 9% reduction goes through the $1 million for Morehouse, they will lose federal funds off of that. Mercer does not receive any federal funds, matching funds right now, but any reduction to the Morehouse operating grant will be a loss in matching funds as well.
So do we know what that loss of federal funds will be, or can you get that to me?
I can get that for you. I'll have to calculate it out, but I can get that for you.
Thank you.
Okay. Representative Stevens?
You said that we're still getting a good deal, so to speak, from the state because of the way that we're funding through Mercer and Morehouse, our private schools for medical education versus public education. And I'm concerned about a 9% reduction. That's rather large, especially since the Savannah campus went to great extents to divide in thirds the cost with Mercer, the state, and the hospital there. Where does this lead them as far with their original promise of funding for Mercer? Do you know?
We have some impact statements. I handed those out in the 11 committee, but I will get those to you again from the schools as to exactly what it means. I did not bring those with me today, but it's with the various, all the schools that are getting hit and the residency programs as well. Things like expansions. They'll have to slow down or stop their class size expansions. Faculty reductions. They're not able to fill faculty positions, and when faculty leaves, they're left vacant instead of bringing in new faculty. It's getting hard for them to function with all of these cuts.
When you're back on your other presentation, you're talking about the physicians in rural Georgia. It's my understanding Mercer only accepts Georgia students.
That's correct.
How does that compare to the other colleges as far as retention? And I've got the numbers for you, retention in Georgia.
Mm-hmm. Are you talking about how many students,
yes,
Georgia students they enroll? I believe MCG is at around 96% on their 98% on their enrollment. Is that in that fact sheet, Kelly?
Is it?
I don't think I ended up bringing my copy up here.
I'm sorry, it's in here. You've got past and projected enrollments. Page 3. Sorry.
Do you have another question, Mike?
No.
Okay. Representative Shelton, do you have a question?
I just want some clarification. I believe earlier in the presentation you said there were 30,000 physicians that are currently licensed in the state. Is that correct?
Mm-hmm.
But there are only 19,000 practicing?
Practicing in the state. That is correct.
And we're making it harder to provide physicians in the state, potentially with a 9% cut. And thank you. And to further, I'm going to go back to your other. I'm still kind of thinking about this loan repayment. Why would a student go to a college out of state for a medical degree? I mean, is it a special area, or why would a student leave the state to practice?
Just their personal preference.
Is it available here? And I guess I just have some concerns because I know whenever you talk about, I know it's different with the scholarship program, but for every $20,000 spent on scholarships, the state yields about $369,000 to $834,000 annually in economic impact. So just curious. Thank you.
Am I correct that the amount that Morehouse will lose as a result of the 9% is $3 million? So Mercer loses $1 million and Morehouse loses $4 million. Is that correct? Because of the federal match? Do I understand that correctly? So Mercer will lose $2 million, which they have planned to use at various places, and Morehouse will lose whatever's here plus another $2 million. Wow. Okay.
Okay. Any other questions or comments? Anything you want to tell us before I go to the next person? Did I leave anything out?
Nope, that's it.
That's good information. Thank you.
Thank you.
Okay, this time we really will hear from Denise Carnegie. You're going to do a primary care workforce presentation. Denise.
Denise Carnegie from the Georgia Statewide Area Health Education Centers, the AHEC network. And I am not an attached agency, and I'm not speaking to a specific budget, so relax. But I do want to talk to you about primary care in Georgia and what's happening in primary care and some ideas as we move forward in this arena. The first, one of the things I have discovered in my long tenure working with the legislature and working in healthcare is that many people forget that healthcare access is not simply about finance. It is equally about workforce, because you can have all the financial access in the world, but if you have no one to go to, you don't have access to health care. I know Dr. Karen Menyard came and talked about financial access and covered that quite well. I'm going to talk about physical access, who you go see, where you go see them, where they're going to be in the future. If you look at physical access, you're talking about providers, facilities, and services. In Georgia in 2006, we had quite a dearth of physicians in several communities across the state. If you look at this, we had 8 counties without a family physician, 27 counties without an internist, 64 counties without a pediatrician, and 69 counties without an OBGYN. When we talk about the providers of primary care, we generally are talking about family medicine, internal medicine, general pediatrics, sometimes OBGYN, sometimes surgery. We're also talking about advanced practice nurses, nurse practitioners, physician assistants, and increasingly the literature is suggesting we should be talking about dentists. I know you probably have heard this stuff till you could puke it, so I'm not going to go over a lot of it, but a couple of facts about primary care. We know that the increase of 1 primary care physician per 10,000 population results in a reduction of overall spending by about $684 per Medicare beneficiary. We also know that the addition of 1 primary care physician per 10,000 population resulted in 3.5 fewer people dying each year. And finally, we know that if you live in a primary care shortage area, this is an independent risk factor that you're going to be hospitalized unnecessarily or in a preventable way. So how are we doing in Georgia? Overall, overall, if you look at our physician to population rates, we're at about 200 docs per 100,000 population. Nationally, it's about 300. You break that down to primary care, we're at 82 docs per 100,000, whereas the national average is about 100 docs per 100,000. When you look at the medically underserved areas in Georgia, it's easier to count the ones that aren't. We are basically blanketed across the state with shortages. And it's getting worse. And when we look at the trends that are happening nationally and both in the state, we know that the number of U.S. grads who are entering family practice dropped over 50% in recent years. In 2007, only 23% of third-year internal medicine students planned general internal medicine compared to 54% in the past. That means even though they're choosing internal medicine, they're not going to practice as general internists. They're using it as a pathway. We also know that fourth-year medical students showed only 2% are interested in general internal medicine for the future. NAC has produced an Access 2015. NAC is the National Association of Community Health Centers. They have been looking at the data nationally and then did a state-by-state analysis. And they said with healthcare reform that basically Georgia is going to add additional 1.3 million people who are going to need health care. They're proposing that 25% of those would be served in community health centers, added to what they're already serving now. So you can see the numbers of the increased patient load that they're anticipating to come into community health centers. How many providers do we need just to meet those needs? Just for the community health centers, we need 88 new PAs and NPs. That is right now. Not in 10 years, not in 5 years. That is now. And 168 new primary care physicians. If we're going to cover all of those new people, we need 351 new PAs and nurse practitioners and 676 new primary care physicians. So these are the current needs today based on healthcare reform and what's coming down the pike. We continue to rank well below the national average in the number of medical students per 100,000 population. This is going to change. We're going to do better on this because we have aggressively been expanding. This doesn't bother me. But here's what does. To make a physician, it is not a short commitment. You have 4 years of undergraduate education at whatever college you want to go to, 4 years of medical school, which is called undergraduate medical education, and 3 to 8 years of residency, and that is the GME that Sherry referred to. So whatever we do today, assuming it's not affecting people in the pipeline, but those entering, it is 11 to 16 years before we begin to see output. Now, my friend Sherry has more current data since she's the director of that agency, so some of these are going to look similar to hers, but I pull them off the internet, not out of her office directly. But you can look at how we're expanding medical schools in Georgia. This is impressive. It represents a commitment and an investment from the state. But that doesn't solve the problem. There's a training capacity challenge here that we're not talking about, and that is as we look at increasing the enrollment, in medical education in the third year, medical students have to do clerkships. And there's between 6 and 7 a year, and 2 to 3 of those have to be done in the community-based training sites. Between 2000 and 2010, we've increased the number by 629 of third-year students who need those clerkships in the community. So we know we have to provide an additional 1,887 4 to 6 rotation sites and communities to help these medical schools graduate these students. They cannot get all their training at the medical school. This is one capacity issue that as AHEC director keeps me up at night, because while we have funding for housing to help support community-based training, we certainly can't support all of it. We've received our share of cuts, and I'm not asking you to change those. I think everybody has to take a hit. But this is serious, because if we can't train them, why are we expanding? And then there's a whole issue of if we get them all trained, where do they go? And that's the graduate medical education challenges. In 2005, there were 24,269 national graduate medical education postgraduate year 1 slots, filled by 18,560 U.S. grads and 5,709 international medical graduates. Now, with all these medical schools expanding nationwide, if the residencies don't expand, we're not going to have room for all the U.S. grads, let alone the international grads. So we're going to be turning away a large number of people in the current pipeline if we don't get more residency slots opened up. In Georgia, we rank 37th in the number of residents to population. We need an additional 1,300 residency positions to meet the national average. We need 270 to reach the southeastern average. Now, 1,300, that's pie in the sky. Even I know that. But we got to do something. And we also have to do something to make sure that Georgia graduates are going into Georgia residencies, because that's how we know that we have the best chance of them practicing in Georgia. Looking at that production of primary care, this is really important because there's a little bit of a shell game going on when we talk about primary care and people going into primary care. If they're not specializing, that means they're really practicing primary care. But if they specialize, they're not. So when you look at that first number, you say, oh, 251 chose primary care. Only 121 of those are actually planning on practicing in primary care. So although 251 or 54% of Georgia Medical School graduates went into primary care, only 81 of them intend to practice true primary care and entered into a residency in Georgia. So where did they go? I call this the great sucking sound. This is where our graduates went in 2009. 350, or 74%, left the state for residency. 26% stayed in the state. 17% pursuing true primary care stayed in the state. That's very sobering. If you look at our residency programs in the state, and you see how many slots we have, how many were filled by Georgia medical students, number and percentage, it's very low. We've got to incentivize our Georgia students to stay in Georgia residencies. If you look at the total residencies by facilities, you'll get an idea that we graduate 618 doctors across all specialties in a given year. We held a primary care workforce summit in November of 2008, the Georgia Statewide AHECs. And one of the things that we said and concluded was that the need to define proven strategies is not the pressing issues. Rather, we need to define commitments. We know what needs to happen. It's not rocket science. It's a simple train of thought, if you will, complex in its implementation, unpleasant in its implementation for some people. But if we really want to change the trajectory, we know what needs to happen and how it needs to happen. I like this slide for a number of reasons, but I look at that and what I see are all the barriers in primary care right now. And I think we're at a crossroads. One of the things I hear in academia is that until we can solve all of those pieces, we shouldn't address any of them. Now, I think that person who has them on his nose probably would appreciate us removing a couple of them. So I'm of the opinion that we have to do this piece by piece. We're never going to solve everything at one time. So there are too many pieces to await resolution of all. We have to begin those steps now. We've done that in essence with funding of medical schools and with the expansions, but we have to keep moving forward. To not move forward is to move backwards at this point. So some of the things that we need to do: increase the awareness of careers in primary care and incentivize these. You know, I'm past the point in my life where I think you shouldn't bribe children. You know, I bribe mine all the time. I think we need to bribe students too. And I also think we need to hold people accountable. If you've got public funding and you've got public need, you need to tie that together. Local collaborations with students is very key to this. We are finding that when communities are engaged with admissions process, they come up with matching funds. They come up with agreements and deals to help these students because they're desperate. We need to increase that opportunity for those to occur. We need to reward students and residents who select primary care. I'm all for a stipend or a bonus payment, frankly. At this point, we've got to do something with those in the pipeline. That's short term. Long term, we need to talk more about who we're letting in the pipeline, because you get out what you put in. We need to create rural and/or primary care tracks in our medical schools. There has been tremendous national research that shows if you have a rural or primary care admissions tract where you identify on the front end these people, they are highly successful in graduating those people to practice in your state. We also need to understand our data better. Sherry is very fortunate in that she has all this physician data. Have you tried to find the data for the other health professions? You can't get it. How do you plan in a vacuum? We've got to deal with that issue. One thing I didn't put on here, but I would suggest to you, is you all have to resolve the scope issues and decide how people are going to practice in this state. Because there is a role for nurse practitioners and physician assistants, but the legislature needs to define that, because that also influences the demand that we're going to have. In May of last year, the National Conference of State Legislators put together a summit on primary care workforce. And Representatives Mickey Chanel and Senator Renee Unterman were our two legislative leads. And they brought in organizations in Georgia to develop a plan. And so we submitted the recommendations in December. The first one is data collection. And I will tell you, I've been doing this a long time. And one of the things that we have is a system based on relationships. If the Secretary of State, whoever's in power, gets along with this person, who gets along with this person, then we're allowed to add questions to licensure and certification renewals. If they don't, then we can't. That is not a system. It is too big. It is too important. We need some direction that the Secretary of State will work with whomever you designate as a health workforce agency so that we can use that licensure certification renewal cycle to collect the data we need for planning. That's how we get it for physicians, and we have one of the best systems in the country. So that's the first thing. The second thing, you're not going to like this one. We need tax credits. The reason we need these is because right now, those third-year students from expansion are popping into the pipeline. We have out-of-state schools and offshore schools who are paying sites in Georgia to take their students. We don't pay sites in Georgia. If we ever got into the business of direct payment to sites, it could bankrupt every medical school in the state. We got to do something, though, so that they'll take our students, Georgia students from any Georgia medical school, for these community-based clerkships. This is probably, in my opinion, the most important thing we can do right now if we want those students to train in Georgia. We need incentive grants for medical schools to implement primary care and/or rural admissions tracks. Again, you can either beat people into it or lead them into it. I prefer to try to lead them into this direction. And the last is a marketing initiative for rural communities and CHCs, because we know they can't afford $65,000 for a headhunter. But if we had some resource in the state that was accessible to them for all of these purposes, then we could help these communities in a very efficient way. There are two issues you're going to have to tackle. Not here. We suggest that you create a task force for 2012. One is GME. We got to do something about the residency slots. If you remember, we need 1,300, 270. We need something, or else our students are going to keep going out of state, and we're not going to get them back. The second issue is payment. If you look at the data, looking at the average salaries of primary care versus specialty, we have got to change that so that students are incentivized to pursue primary care in the state and that they can make a productive living. Those are the recommendations from the national conference. Those are just some overview data of primary care in Georgia, and of course I'm willing to take any questions you have or comments. And I'm having a personal summer, so y'all just, I'm of that age. Might as well just tell y'all.
Denise, thank you for a very informative presentation. Some questions for Denise, anybody?
I'm curious. I didn't realize that some foreign graduates or medical schools pay the sites like they would pay pay a hospital. No, how does it work?
All kinds of different ways. The tuitions at medical schools and the offshore schools, a lot of them are for year one and year two, and then they're responsible for setting up their clerkships in year 3 and 4 back in the States. So they pay site to take them. There's not any oversight in Georgia of that happening. In some states, there has been legislation and or rule enacted so that if you want to come in from an offshore school, you have to come in through a Georgia medical school. They have to approve you and say that you're in academic good standing and that you're not displacing a Georgia medical student.
Do you have numbers to show how pervasive this is? I mean, is this a known
I have some.
trend? You have some.
I can get you some stuff.
Give me an example.
Well, you have an offshore school who's paying $1,500 rotation in some cases. It's between 4 and 15. Because there's no limitations in this state, we had a situation in northwest Georgia where one physician took, I believe it was 9 students at one time. Thank you.
A physician took 9 students at one time.
To precept.
And
they got, let's say, $500 for each one of them. We can't do anything about that.
$500 a year?
No, rotation. And remember, they have to do 6 or 7 in their 3rd and 4th year. And Florida State University, not to name names, has started paying sites in South Georgia to take their students. Interestingly enough, they are using federal funds to do that, but they can't pay sites in the state of Florida because they're encroaching on other medical schools' territories. So they're using their federal funds to buy sites in Georgia.
So what is there in the Florida law that isn't in the Georgia law?
Well, in the Florida system, it's just because they have 6 medical schools and they've defined their territories very cleanly, and they're almost like Berlin walls. So they know they can't fight their own medical schools or they'll get in trouble with their own legislature. So they just come up here. And it's created a lot of problems in South Georgia.
How long has this been going on?
About 4 years. And it's getting worse.
Other questions? Please talk to us a little bit. You touched on this idea of sharing data and the good information that Sherry has on the physicians. It sounds like the best way to get a handle on that is if through the Secretary of State, the boards, as they renew their licenses for nurses or PAs or whatever it is that
Absolutely.
about right?
It is so simple, especially with the online renewals. You just add the questions and ship the data over to what entity is designated to receive it. It's the cleanest way and the best way.
Well, who actually makes that decision? Because most of those boards are just attached to the Secretary of State's office for budgetary purposes, right?
No. Not the health licensing boards. They're a division, I believe, under the Secretary of State's office. But what we have found is that there has been no one at the Secretary of State's office willing to say, we're all in, we're going to do this. So you have to negotiate with each individual board. And depending on who's the current board director and the board chair, you may or may not get them to agree.
Well, that's what I mean. The boards are basically independent, right?
The boards are.
Yeah, so
you might have to negotiate with 14 boards.
Yeah.
And if you only get one piece of the puzzle, you still have an incomplete picture.
Right.
And it would be so easy just to institutionalize this, add those questions to the online renewals, collect the data, send it to academia somewhere for people to analyze it. Don't send it to me, but.
Okay. Other questions?
Well, and I hate to suggest that, but the fact of the matter is we've relied too long on personalities and relationships. And then there's a change of leadership, and you have to start all over. So you lose 4 years of data. And then you finally get it working again, and dadgummit, someone moves on.
Ask her to.
And we can't keep doing that.
Representative Shelton has a question.
Yeah, could you give us some specifications on what type of data you'd be looking for?
Oh, it's very simple. It's what's the zip code of where you live? What's the zip code of where you work? What is the percentage of time that you're working? We have a lot of situations, if you just look at the zip code of their residents in Atlanta. How many people live outside of Fulton or DeKalb, but they work in Fulton, DeKalb? We have to know where they're working as well as living, if they're working clinically or if they're working in administration, because that's very different. We have to know if they're even totally out of the profession. I know with a lot of nurses, for example, people keep their licenses and don't practice clinically. So we need to ask very basic questions. I'm talking 15, maybe 20 maximum. And some of those would be included in the ones already being asked, which we're not given access to.
Would they be consistent across all the different boards?
Yes.
Okay, thank you.
Why don't you get us a list of those questions?
I can take a stab at it, but yes, I will.
Okay, great. Any other questions?
Thank you.
Thank
I
you.
appreciate this opportunity.
Thank you. That finishes our agenda for this afternoon. And any other questions or comments from the committees before we adjourn? Our next meeting is going to be
Thursday.
yeah. It's at 1 o'clock over here.
Yes, sir. 1 p.m.
Our next meeting will be Thursday at 1 p.m. in this room, and anybody that wants to be heard needs to go by 2:45 and sign up so that we can put you on the list so we'll know how to do that. Thank you all for coming.